So these are the different types of malocclusions that you will commonly see in a patient. So when a patient like this comes in front of you, number one, you want to see that you can't even see the lower teeth. What is that called? It's 100% deep bite. The second thing you see is you see a gap in the upper teeth. So you see a spacing. Now you see how bucked the teeth are? So this most likely is a class 2 division 1 100% deep bite with upper midline diastema spacing. So that's how you describe the malocclusion. Number 2, this is an open bite. Now this looks like a skeletal open bite. How do you confirm if it's a dental open bite or a skeletal open bite? The only way to confirm is by making the measurements of the skull using the cephalometrics, which as an orthodontic assistant, that's something you need to know how to do, but as an RDA-EF, it's not within the scope of your program. If you're interested in learning, I'm happy to share some videos with you. So reach out to me personally, and I'm happy to give you that extra piece of information. Now, number 3, as you can see, is an underbite or a doggy bite. This person has a reverse overjet and a reverse overbite. So if you look at this picture, number 4, it's right behind here. You can see it's 100% deep bite, but you see the upper incisors are kind of tucked in. So this is a class 2 division 2 malocclusion. All right, the next one I want you to look at is arch-formed relationships. Now, the one type of occlusion is the molar classification, the malocclusion classifications by Edward Angle. The second one is there a deep bite or is there an open bite? We just looked at that. Now, another type of categorization of malocclusions is how are the teeth sitting at the back, or the sagittal relationship of the upper and lower jaw. So if the teeth are sitting like this at the back, normally, that's just a good occlusion at the back. But you can also have a crossbite posteriorly like this, where you see some children come in where their upper teeth are sitting inside of the lower teeth, or it can be the lower teeth sitting inside of the upper teeth, like in this picture right here with B. So this kind of a bite where the upper and lower teeth are not occluding properly and the upper teeth are sticking out, this is called a broody bite. A cross bite is an opposite of this, where you'll see the upper teeth inside and the lower teeth outside. So that's the difference. So there's a difference between a cross bite and a broody bite, and I'm going to show you some jaws when we are talking today in our Zoom/Google Meet lecture. I'm going to show you the difference between these things. So when the top and bottom teeth touch each other, they leave some marks on the teeth. So if you take an occlusal paper and grind and look in the mirror, you'll see some dots on these teeth. And this is the contact points that the top and bottom teeth are making with each other. Usually you will ask the patient to grind side to side. Mrs. Jones, can you bring your jaw forward, please? And grind side to side this way, side to side that way. Fantastic. Thank you so much. So this is how you guide the patient into biting on your occlusal paper. Why are you doing that? You're doing that because you want to see where the upper teeth are coming in contact with the lower teeth. So these are nothing but they're called points of contact, or these are where the upper teeth are coming in contact with the lower cusps. Okay? So as you can see, each and every tooth has that relationship. But when a bite is off like this, like I just showed you in this picture, you're going to see the contact is also off to the side. Usually the contacts are in the middle. Usually the contacts are going to be here, 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 here. It's usually in the middle along the line here. But for this person, it's all off to the side because this person has a wrong bite. So the top teeth are basically making contact only at these points, and the lower teeth are only making contact on these points. So in the long run, what is going to happen with a bite like this? A patient is going to have pain in their joints, and this is not a stable bite. It's going to cause degeneration of the cartilage. So in a good bite, where your top and bottom teeth are in good occlusion, what do you see? You see that the top teeth and the bottom teeth form a relationship like this, as you can see right here. Now, the points, the upper molars and the lower molars come in contact with each other. When you grind side to side, forward, you can see the movement these arrows are making. That's basically showing the movement. The molars are making this movement. And in that movement, these are the points that come in contact right here. These are the points where the upper and the lower molars touch each other. So these are called, where you get two points of contact on the upper. These are called the dipod contacts. And in the bottom, in the lower arch, the distal-buccal cusps of the mandibular molars make fossa contacts in 3 points right here. So these are called tripod contacts. All right. So the maxillary supporting cusps, what you need to know is that the maxillary premolar lingual cusps make fossa contacts in the distal fossa of the opposing mandibular premolar. So if you look at your upper maxillary premolar in the mirror and you close down, you'll see that the lingual cusp is the one that is touching the fossa contact. It's not the buccal, because the buccal comes outside. It's the lingual one that is actually coming in contact. Now, the maxillary molar mesiolingual cusp makes fossa contacts in the central fossa. So you need to know which one is making contact. For the maxillary premolar, it's the lingual cusp. For the maxillary molar, it's the mesiolingual cusp. So this is the, if you imagine, this is the midline of the body right here. This is the mesiolingual cusp right here. This is the distolingual. So it's this cusp right here, which is the mesiolingual cusp, which is making contact with the fossa in the lower. Okay. Now, why is this important? Why are we talking about this? Because when the dentist is restoring, or when you as an EF are restoring the filling, first of all, you want to restore it to the original anatomy of the tooth. So how do you know where the original anatomy of the tooth is? Before the dentist cuts down the tooth, sometimes it's good to take an alginate impression or a quadrant impression of just that tooth, or look at the opposing tooth. The opposing tooth will tell you a lot about the anatomy of the tooth. And you want to recarve or bring back the anatomy. Because if a cusp is, say for example, if the cusp is like this, and when you're restoring the tooth, you make it flat like this, okay? Then this will not have any contact with the lower tooth. That's why you want to restore it back to its original cusp height, because only then will the patient say, I can feel like I'm chewing my food. If not, they'll say, I can't feel anything on that side. I can't feel anything on that side. Or they'll say, I feel too much. When they're saying I feel too much, it means that you want to lighten the contact. If they say I don't feel anything at all, that means that there's no contact and you need to increase the amount of material. It's a fine balance. Now, this is what an ideal intercuspal contact scheme looks like. The cheat sheet that I use, you can print this out and keep this as a cheat sheet, but I just use the patient's bite. When I ask them to bite down on the occlusal paper, that itself is my cheat sheet, because I can see all the dots right there that the patient is making for me. And I try and leave the dots exactly the way the patient came in with the dots. When they leave, I make sure that the dots are in the exact same position. Say, for example, I do a filling and the dot from here shifts over here, say right here. And the patient tells me, I'm feeling a high spot. When I'm closing down, I'm feeling a high spot. Then what do? I take a burr with a white stone and I gently take out that orange spot that I just created until we get back to the original spot, which is right next to that. So it's just, you don't have to memorize all these different spots, but the way you can even look at it in the patient's mouth is just have them bite down on the occlusal paper. A nice trick that I teach my students in the Pitt and Fisher sealant course, and for those who have done the course with me, you know that I ask you to have the patient bite down on the paper before you're starting your sealants. And then when you finish your sealants, you know that all the places where you have a dot, you want to make sure that those places are not covered by sealant. Because if they are covered by the sealant, the patient is going to tell you it's too high. Or at least you know that you need to bring down that sealant in that area before the patient leaves. All right. So if you look at a good bite where the upper teeth are in good contact with the lower teeth, it creates this picket fence kind of look. And this is sometimes a question they ask on the board. It looks like a picket fence. So you just need to know the upper canine is coming in occlusion with the lower canine and the lower premolar. The upper premolar is in occlusion with the lower premolar, premolar 1 and premolar 2. The upper premolar 2 is in occlusion with the lower premolar and the lower molar. The upper molar is in occlusion with the lower M1 and M2. So if you remember this picket fence diagram, you'll know exactly which tooth. This is for a class 1 canine and molar occlusion. You'll know which tooth is, it's always the upper tooth is coming in contact with two teeth on the bottom. So just remember that it's usually the upper will come in contact with this and this. The upper will come in contact with this and with that. It's just the last molar that does not have two teeth contact, but it's just a one tooth contact because there's no other tooth behind. All right, so we spoke about why do we check these dots on the teeth. We check these dots or the occlusal contacts. They're called posterior contacts. You want it to be well distributed. If not, the patient is going to have pain. They're going to come back and say, I'm feeling a high spot. So the couple contacts between the opposing teeth are very important. And for overall tripoding is where each tooth is supported by the other tooth in a tripod-like fashion. So if you destroy this original relationship that the human being has, patient is going to get pain in their joint. They're going to come back with other problems. All right. So the mandibular movements, what you need to know that the mandible is the only joint in the body that is attached to the maxilla and it opens this way. And it can rotate around its axis. And it can move this way and stop right here. The mandible cannot go backwards, but it can move forwards and it can move sideways. So the midline of the body, so if you draw a midline right here and imagine the mandible can move around its axis. This is its axis, right? The mandible can move towards the midline, which is through the, if you look at this being the center of the body, the mandible can move towards, it can move away. So this side movement, that side movement, and forward. These are the different movements the mandible can do. So defining mandibular movements. So the excursive movements are defined as any movement of the mandible out of intercuspation. So when you're in intercuspation, you mean you're like this. Excursive movements is movement of the mandible outside of that. Protrusion is where you're bringing the lower mandible forward. Anterior movement. Lateral protrusion is side to side movement. You can bring your jaw half this side or that side. So if you're moving the jaw towards the midline, it's called mediotrusive. If you're moving the jaw away from the midline, it's called laterotrusive. So you draw a middle point in your body and call it the midline. If you're moving your jaw towards your midline, it's called mediotrusive. You're moving it away, it's called laterotrusive. Retrusion is where you're trying to push the mandible back, but that's not possible. Why? Because the mandible is stuck in the foci, so that's not really important. So there are many factors that also determine these mandibular movements. Let's say you have a tooth with a very deep anatomy and it's catching the upper teeth in the cusp. It can be a deep groove or a pit, or it can be that the intercuspation is off. Say you do a filling, a nice composite filling, beautiful one, but it's very, very high. What's going to happen? This intercuspation is off, so the patient will not have a stable bite. They'll keep moving into mediotrusive or lateral trusive movements all the time. They want to have a nice stable bite. They'll be moving this way. Guidance of the tooth position in the arch. The position of the tooth in the arch is very important. Sometimes when you lose one tooth in the lower, the upper tooth begins to migrate down. And that sometimes changes the way this mediotrusive and laterotrusive movements occur. Cusp height and inclination. Now, if you make a crown which is extremely tall, or you make a crown with extremely high inclines, sometimes it stops these natural movements of the mandible. So that's why this is important for you to understand what the natural normal anatomy is before you start reconstructing the tooth. Because if you reconstruct the tooth too high, too low, a crown which is too deep, or too deep an incline, or too high a crown, sometimes a patient will say, oh, this is too high, I'm getting pain in my joint. That's why this is important for you to understand. Now, the mandibular condyle also, now there are two factors that actually determine the mandibular movements. One are the teeth. Two, it's the condyle. The condyle itself has two kinds of pathways. When you open your jaw, some people, when they open their jaw, the pathway is pretty steep. And for them, it's okay to have a little bit higher crowns. But for people who have worn out their dentition all their life and have a very narrow pathway of opening, you cannot give them very high crowns. And this is what this means, that you need to look at the condylar inclination in the immediate side and the progressive side shift. That means when they're shifting, what is the inclination of the condyle? And you also need to look at I'm going to talk to you about what Bennett angle is in the next lecture. But what you need to know is, how is the condyle rotating? How is the condyle translating? What are the movements of the condyle? And if these movements are recorded properly, then you know that you have done a filling or a crown to the best of your ability.